I'm very proud and happy to be part of the creation of our new association, and I welcome you very warmly to our first meeting. This session will treat the impact of COVID-19 pandemic on the surgical outcomes and mortality, and I will share this session with a very dear and friends and colleague, Dr. Abdulrahman Sheikh, whom I welcome. He's a vascular surgeon in Gaza Strip in the European Hospital. And Dr. Alexandre Carsanti, which is a thoracic and vascular surgeon in Marne-la-Vallée Hospital in Parisian region. Let me start with this study we performed in our institution, the Assistance Publique Hôpitaux de Paris, on the surgical outcome and mortality. We recently published in the British Journal of Surgery. So, Samia, can I share my screen, please?
Yeah, for sure. You normally you are allowed.
You see. Yes, I have to activate that. Okay, I will activate. Partager l'écran.
Great.
Yes, you see my slides? Okay, perfect. So the impact of COVID-19 pandemic in surgical mortality. So I was involved in a working group in our institution, Assistance Publique Hôpitaux de Paris, and this group was responsible of the surgery and COVID-19 during the first wave. So you see here the name of surgeons, doctors, epidemiologists, and statisticians. In France, the Île-de-France region, one of the greatest region in France with a population of 12 million, was one of the most affected area in France. And during the pandemic peak, more than 2,600 COVID-19 patients and 700 non-infected patients were hospitalized in ICU, with 80% requiring life support ventilation. And hospitals around the world adapted their organization with dedicated path for COVID-19 patients. We decided to postpone all non-emergency surgical procedure in order to double the number of free ICU beds. So the most of elective procedure were canceled except when considered mandatory following guidelines. So the point of my presentation is to provide a view of the risk associated with surgery in COVID-19 patients based on a retrospective cohort of more than 6,700 adults patients operated on in our institution between February and May 2020 and tested positive to SARS-CoV-2 using RT-PCR. So we assessed the mortality rate and pulmonary complication within 30 days after surgery and patient group related to RT-PCR results and phase in pandemic progression. And the aim was to identify the association of COVID infection and outcomes following surgery, with the hypothesis that COVID-19 status could be associated with a higher 30-day mortality and pulmonary complications. So we included in our study all adults inpatient with at least one PCR result and one surgical procedure between February and May 2020. The date of inclusion into the study was defined at the date of admission, and the end of follow-up was defined as one of the following: time of death, discharge home, and day 30 after admission, whichever occurred first, or administrative censoring on June 17. The primary outcome was all cause of 30-day mortality. The secondary outcome was pulmonary complication. And for all the patients, the following parameters were recorded: the age, the sex, hospital ICU admission, hospital stay duration and ICU stage duration, comorbidities, and risk factors. Pulmonary complications that occurred after admission, defined by acute respiratory distress syndrome, pulmonary embolism, and acute respiratory failure, were also recorded. From February to May, more than 16,000 patients benefited from a surgical procedure in the Assistance Publique Hôpitaux de Paris. And from this group, 6,700 patients had available positive PCR results. The overall percentage of operated patients that benefit from RT-PCR was low during the first wave, only 42%, but it was increasing with time. In the beginning of the wave, 27% of operated patients had RT-PCR, and approaching May, 78% of these patients had the COVID test. The overall death, all surgical procedure included, within 30 days was 4.9%. And there was a significant difference in death according to the patient group. The highest mortality, almost 18%, was in patient positive within 5 days before surgery, the lowest in negative patients. Mortality within 30 days was different also during the peak phase, 8.9, comparing to the pre-pandemic 3.8 and post-peak 3.9. Overall pulmonary complications were 18%, but there was a significant difference in pulmonary complication between the groups. The highest rate was more than 51% of patients positive within 5 days before surgery. The lowest were in negative patients, and during the peak, the pulmonary complication rate was higher. If we take some publication in the literature, we see that the mortality rate was very important also in other studies, 23%, 30%, 44% in some studies. And concerning the pulmonary complication, the rates were around our results, with more than 50% pulmonary complication in this study and 40% in after lung surgery in the CAI publication. On the contrary, some publications didn't demonstrate difference in mortality or complication between before and after pandemic, but these studies had limitation because of the low number in positive SARS-CoV-2 patients, the absence of control group, and the date in which surgery was performed relative to COVID diagnosis was rarely defined. So the SARS-CoV pandemic led to a larger scale cancellation of elective surgical procedure and to the establishment of priorities for the procedures, oncology and trauma surgery. And a better evaluation of risk are still needed to develop guidelines for surgery in COVID-19 patients. So we showed in our study that patients with positive SARS-CoV-2 RT-PCR within 5 days after surgery had more than 3.5-fold increased odd risk of death and 1.5 increased odd risk of pulmonary complication during the 30 days after surgery. And a history of SARS-CoV-2 infection positive more than 4 days prior to surgery was associated with a higher risk of death and very higher risk of pulmonary complication. So this result indicates that further investigation are urgently needed to assess the post-critical consequence of COVID in order to better estimate surgery-related risk. And the patient with previously positive SARS have to be considered at higher risk of pulmonary complication and death in the first 30 days after surgery. The limitation of our study is that the data was collected during a specific period and including the peak of the pandemic, and a limited surgery was performed, and the criteria to be included in the positive group was to be positive for at least 1 PCR, and we know that there is no strict consensus for diagnosis of the infection. So based on this retrospective study, we suggest that during the active phase of the pandemic, surgical patients should be isolated, if possible, at least 5 days before their procedure in order to avoid any contamination. And a patient with previous history of SARS-CoV-2 infection should be considered for potential middle-term or long-term pulmonary complications to decrease the risk of postoperative complication or death when scheduled for a surgical procedure. You have here all the reference of I used to do my presentation, and thank you for your attention.